Good afternoon, and thanks for attending today's webcast, the 2015 series. Today's webcast is entitled Migrating EHRs, Ways to Prepare for and Convert Your Clinical Data. Your phone has been automatically muted, so please use the Q&A panel to ask questions during the presentation. Following the presentation, we'll pick questions and answer them as entered, and as long as time allows. So once again, thanks for attending today's webinar and webcast. My name is Taylor Moyer, and I'm a Senior Technical Consultant at Galen Healthcare, specializing in data conversions and data extractions. I'll be presenting today on the topic of converting your clinical data when migrating your EHR. Today, I hope to cover the following topics, with the goals being to educate and provide key points that help you as a healthcare organization know and understand your clinical data conversion options when migrating EHRs. Well, why do we migrate EHRs? Healthcare has changed a lot since the early to mid-2000s, when a variety of healthcare organizations started converting their paper medical record to electronic medical records. Some of the following reasons that we wish to migrate EHRs today are industry consolidation, provider dissatisfaction, lack of integration, and lack of vendor agility, to name a few. So industry consolidation. 2014 was one of the most active years for merger and acquisitions. Typically with acquisitions, health systems acquiring ambulatory groups with separate EHRs are looking to migrate the data. It typically involves a mutual agreement to move existing patient data into the acquirer's EHR. And mergers would typically consist of large group practices or health systems merging to form a larger entity. And the scenarios that you would find in mergers are, depending on the merger, a replacement EHR could be selected, or one of the two existing EHRs will be selected as the primary EHR, meaning that you could be converting two data sets into a new EHR or converting one into the primary EHR. Another reason for migration of EHRs is end-user dissatisfaction. According to a study by Software Advice, there was a 59% increase in groups looking to replace their EHR this year. The primary reason for that was dissatisfaction of the EHR. Is why they're looking to migrate, with the biggest complaint coming from the end users saying that their existing EHR is either too cumbersome or too faulty and impacts end user productivity. Third reason for migrating your EHR may be that you have a lack of integration. Your current EHR and environment requires multiple interfaces and manual processes to accomplish what should be an automated process. You could also have a complex internal infrastructure that's costly to support and maintain. And you're looking to find opportunities to improve efficiencies and reduce costs through a more integrated platform and single vendor. And the fourth and final is lack of vendor agility. What I mean by that is the vendor or vendors have been unable to pivot against the wave of oncoming health IT initiatives. The focus on initiatives has impacted their functionality and performance of their system. And I've included some chaotic images at the bottom just to get an idea of some of the issues that you may be dealing with as an organization, and that the EHR vendor has to manage and manipulate their system to achieve these goals before they can even deliver it to you as a customer. So with that, we're going to send it back to Alan, who will have question number one for our audience.
Thank you, Taylor. For the first poll question, I'm going to open this right now. We're just looking to see who our audience is, if you're planning on migrating EHRs, and then if so, what time period you're looking for. So I will leave this open for about a minute. and I'll kind of summarize the results. It looks like so far we've got most people are looking to migrate within the next year, and a couple people within the next couple years, and a few people that aren't looking to migrate but just kind of looking for some more information. So we've got a good mix of people on the phone. I will leave this open for about another 30 seconds, but I'll pass it back to you, Taylor.
All right, thanks, Alan. So the next slide is a picture that I used for a blog post last week in regards to the options and the need for a clinical data migration. So what I wanted to use this for was a stopping point to kind of paint a picture with a clinical data migration through the eyes of three different stakeholders in this. The first one being a patient, the second one being a clinical staff member or physician, and the third being administration or management. So if you're a patient and you are seen by an organization that migrates through EHR, and there's a delta between the time that you last visited when they're on the former EHR and you visited again when they have or have migrated over, you know, what data expectations do you as a patient have for this organization? Where would you feel that they need to converge your data in order to ensure that there's a continuity of care between your last visit and today's visit? The second is from a provider. Your provider, a clinical staff member coming in, and your patient, from the perspective of the patient, comes in and you're trying to review their last data. And with the options that you may have, is it going to would you prefer to have the data into one solution where you don't have to go between sources to find the data of this patient? Will it be painful or cumbersome for the clinical staff member to perform another onboarding of that patient, capturing some of their key clinical and vital data, such as allergies and meds? And what impact does that have to the efficiency of your clinical staff based on your patient volume that you typically see on a given week? And the third is from management or administration that's taking a look at these data points to be able to report on clinical quality measures such as PQRS or meaningful use in order to determine efficiencies and utilization of these metrics for reimbursement. And particularly from the solution that they do this reporting from. Is the reporting going to have to be run from two different data sets, and they have to review two different reports over a span of time until that time expires from the legacy system? Or does it make sense to bring the data into one reporting system through the EHR migration so that there's less work to be done on the reporting and management of that data? So think about those three perspectives as we go through ways to prepare and questions to consider when migrating. So I've listed a bullet points of 5 ways to prepare and questions to consider when migrating EHRs. The first is vendor and resource selection, followed by understanding the data available for your converting, understanding your timeline and data, maintaining continuity of care, and medical legal requirements. Vendor and resource selection. So on the EHR vendor selection, when you are pursuing an EHR migration, and this is to make sure that you consider the options of clinical data migration when you're in discussions with your EHR vendor that you're looking to migrate to, or during your planning process when you're discussing it amongst multiple options. Make sure that you understand what supported options they have for data migration. Do they have the ability to receive and file HL7 messages or CCD, continuity of care documents that should make discrete data conversion more structured? Do they support the use of stored procedures, which are typically handwritten or tested by the vendor or a conversion vendor to get that clinical data discretely into the EHR? Do they support a delimited index file, which is a list of files per data element that lists data points that would be pulled from your EHR and then turned into the format that the vendor specifies to be loaded in by the vendor themselves? So it's key to understand what data is available for conversion, so that during the planning process you understand what data you need to start looking at from your source system to determine if that data can be pulled and converted discretely or in other ways into your target EHR. Also, you want to consider your conversion resource selection. With experience with the EHR data being an important measure to identify from sources when you're looking to do your EHR migration. And experience with the EHR data, meaning does the resource, whether they're in-house experience, if you have technical resources that are capable of doing the conversion, or if you look for a conversion vendor with experience. And by experience with the EHR, again, I mean, do they understand the data sets that are in the source system and understand the process that's involved in extracting the data out of the source EHR and transforming it and then converting and loading it into your target EHR that you're migrating to. Next, you need to understand the data available for converting. The key focus on the data available is the integrity, quality, and usability of that data. On an integrity standpoint, can that data come straight out of the EHR without being having its integrity modified through any processes that need to be performed and getting it from the source to target EHR? Is it a clean push from the source to the target system? What's the quality like in the EHR? Does the workflow that your clinical staff use put in quality data, or is it based, or is the workflow to a point where, for example, for problems, there's different workflows that would require some additional work to be done to determine what that value really is within the organization? And then usability. Can that data be used in the target EHR? That goes back to the vendor resource, the EHR vendor selection. If you can pull discrete data or data elements out of your source EHR and your target EHR, use that data. The typical options for clinical data conversion include, but are not limited to, medications, problems, including problem histories that are social, family, past medical and past surgical history, allergies, and immunizations, notes and scanned images, vitals and clinical observations. One example for the clinical observation that you may not be seen as a vital is a smoking status that needs to be kept in and potentially converted to maintain smoking status as part of a reporting measure for your environment and organization. And then finally, lab, imaging, and other results. And that segues right into the next one, which is identify the source of truth. The source of truth, meaning where does that data stem from? Where is the originator of that data? Is it based on a geographic? Is that, for example, if you are merging with a local environment, local health system, is the geographic location of that data potentially being duplicated by the acquiring entity or one of the merging entities? For example, medications and allergies are typically noted every time in every office, regardless of where that is. So on a conversion to a larger entity, they may already have that medication and allergy data. The same goes with mergers and acquisitions. In considering that, are you merging with a group that may have a lab that you had ordered labs from? Are they solicited labs? Are they unsolicited labs? And are they point of care tests? You may have an example where you're dealing with LabCorp, and LabCorp may not be available for access. You would want to convert that data into your migrated EHR. You also may have point of care tests if you're a primary care facility where you had internal labs that never left the system and are only stored internally into your EHR. And then another thing to consider for lab data or annotations, if you have solicited or unsolicited labs, that have been interfaced into your EHR? Have there been annotations that have been added to it? So if you chose not to migrate labs because of the system you're going to already had that lab because they were the source of truth, are there going to be annotations that won't be included in the conversion that would be medically necessary? Another example is internal versus external radiology, where you may have a radiology department that captures internal radiology, but you may send large radiology tests such as MRIs or CTs to another organization, and if you're merging with that organization, would you not need to convert certain radiology elements such as MRIs and CTs because they are the source of truth for that data element? Another consideration are mappings. When you can do a data migration, are there opportunities to use industry standards such as RxNorm, ICD-10, or SNOMED so that you can perform reports based on those industry standards? Then finally, for data for conversions, we find that it's helpful to develop clinical baselines during the planning process, meaning that you want to define what elements within each data type should and can be migrated. For example, I use the notes or clinical documents. Such data elements that we would recommend would be something like a document ID from the source system that would be a unique ID for each note, the visit date time associated with that note, obviously the content, typically in RTF format, the authoring provider, document status, document type, and updated, scanned, or dictated date and time. Now this is just an example, and what I mean by should and can be migrated. You may decide that some of these are not worthy of being migrated. You may want to include more. And then the second part of can is, can that target EHR that you're migrating to accept the data in that form? So we'll break for question number 2.
Thank you, Taylor. So this segues into our next poll question. We're just interested, and you can check all that apply, what elements are most important to you. So we've had some clients that are only interested in demographics, some that are just interested in scanned images, or maybe they want to do some sort of chart summary. So we're just interested in what type of elements are most important to your organization. And it looks like so far, kind of across the board, the medications, allergies, labs and imaging, it looks like those are pretty important. Demographics also important, but not for demographics only. So got a good mix here. It looks like everything is important to everyone. I'll pass it back to you, Taylor.
Thanks, Alan. So the next question to consider when looking at migrating EHR is know your timeline and data. So some questions that you want to ask yourself are, when is your go live date? Is that go live date within a reasonable time to plan a sufficient conversion? Will you need to modify your plan based on a go live target date that is closer than is reasonably near to perform a full assessment and conversion of your clinical data? Data migrations do take time, so keep that in mind when planning the clinical data migration portion of your migration to a new EHR. And then another option to consider is, as far as your data, is how large is your data set? Has your data been in your EHR for 1 to 2 years or more? Do you typically have a patient volume that over a certain span would include 250 to 500,000 patients? Based on the size of your patient population, the data elements grow exponentially. Another key consideration in data migration is answering the maintaining continuity of care question, which focuses the placement of migrated data into the new EHR that facilitates efficient and effective delivery of care. Meds, problems, allergies, notes, results were all items that were mentioned in the last poll. So maintaining the continuity of care between the migration of the EHR, what key elements and the timelines of those elements are key to your organization to maintain that continuity of care? Do you see one patient in an office once a year, or is it episodic? Or is it like a primary care where it's a continuous involvement of the patient's history? Understanding that and being able to define how you want to maintain that continuity of care impacts the type of data that you want to migrate. So asking that question with an impact on providers and patients will help you determine and value those data elements that you just voted on 2 slides ago. The second one is the medical legal retention requirements. So you have the first question, which is your continuity of care. The second one is how long are you required to keep data. The medical legal retention requirements vary state by state, so the best way to do that is to check with the state code of the state that you're practicing in. Most states vary on a variety of factors, including facility type, whether you're a hospital or medical office, the patient's age, whether it's an adult or minor. It could be a mixture of the two. For example, if you're a hospital in Connecticut, the retention of a record is 10 years after the last discharge or 7 years after the last office visit. So knowing and understanding these 2 items are critical in determining your strategy for the clinical data migration. So now that we've contemplated and discussed ways to prepare and questions to consider, what are our options? What can we do with this data? I've listed 7 options that I'll go into a little bit of detail of each and describe some pros and cons that you typically encounter when looking at these options for clinical data migration. So the first one, always have the option of do nothing, right? So do nothing, leave 2 systems in place to access and manage. The pros is, well, there's no clinical data conversion required. The cons are that you're maintaining 2 or more systems, you're paying support for those systems, and you're also inconvenienced by logging into multiple systems to obtain the clinical data and reporting for your organization. So there is an option for the do nothing, and that is what I would call a reduced licensing agreement, where some vendors would agree to reduce the existing licensing costs for the application to remain in its current state. So the pros are that it's typically cost effective. You get to maintain that same EHR, but for a reduced rate because you're not using upgrades, no use of support. There's no conversion of clinical data required, the same as do nothing, but the cons remain the same. The data remains separate, inconvenient for clinical staff and physicians to access, and you're still maintaining an additional environment. You may not be paying support for it, but you have resources and capital expenses that are still being used to maintain that equipment. Third option is manual entry, which requires existing staff, tech staff, or vendors to hand enter data into the new EHR. So the pro for this one is that clinical data can be entered discreetly into the target EHR via a manual process. The cons are that it's a time-intensive process that may impact patient care post-go-live. It's also prone to human error. If you have a variety of people entering data, you can't guarantee that the data is entered the same way and entered correctly every time. And it may prove costly based on chart volume. For example, if a vendor comes to you and wants to do $10 a chart and you have 500,000 patients, that may not be cost effective for your organization. Now we start getting into some of the options for technical services in a data migration. So the first one is a discrete data conversion. And I referenced the name discrete earlier in the presentation and didn't define it there. But what discrete is an electronic transfer of data from the source EHR to the target EHR. The graphics here almost puts it in proper perspective. You have clinical data, you have a migration and mapping process to make sure that that data is aligned so that it's a medication of Tylenol gets mapped and sorted into the target EHR with the same description, strength, dose as was in the source system. So in this process, you have a meds to meds conversion, a allergies to allergies conversion, a notes to notes conversion, and separate data streams that go into the target EHR. So what are some of the pros of this type of discrete data conversion? So the pros are that it provides actionable data into the EHR that allow your physicians and clinical staff to act on the data that's been entered into the target EHR that would have been available to them in the source EHR that you migrated from. It also drastically improves the continuity of care and physician efficiency following the EHR migration. Physicians and clinical staff don't have to go between systems to determine and find out which data was documented and acted upon from previous visits because it's in their target EHR for them to see and react and make medical decisions on. It also allows for a transition of clinical metrics to be carried forward to the new platform. So discrete conversions also minimize your impact on your quality incentive reporting programs by integrating converted clinical data with your current clinical data for your entire patient population. So some of the cons would be that this typically involves a one-time capital expense. So probably not a newsflash, discrete data conversions aren't free, and also requires a higher resource utilization on the conversion team for validation. Because you're doing a discrete data conversion, you need to make sure that the data that's being put into the system goes through a thorough testing process to make sure that the errors are reduced and eliminated so that the data being placed into your target EHR is the data that came from the source EHR. There are lots of processes and testing that's put into place to make sure that this validation occurs. The fifth option is what I call a chart summary data conversion. This option is a creation of a chart summary, typically a PDF, that's imported into your target EHR. As you see in the graphic below, the chart summary typically combines the key data elements that have been identified as being relevant to your data migration that gets sorted and placed into a chart that's output as a PDF and can be imported into your target EHR. So the pros are there's one document to cover the entire patient history. You also have improved ease of access to data because that document being imported to the EHR is in your migrated EHR, and you do not have to go back to your source system to look for the data. Typically, the chart summaries are more cost-effective than discrete because there's not a large mapping and testing exercise in the data validation. And it also has the potential to meet retention requirements. Now, potential meaning that there could be a variety of options that you need to have to meet retention requirements. And designing the chart summary would be key to consider some of those factors in retention as to whether or not it does meet those data retention requirements. The cons with the chart summary migration are that there is no actual data in the EHR. If a physician wanted to look at the allergies, they'd have to open up a PDF, find the allergy link within the PDF, and read the allergies. So the second con would be time-consuming for a provider looking for specific data. If it's a note and this patient has a long history of visits to your clinic or hospital, and it's a note you're looking for that's 2 years old and you have to scroll through hundreds of notes, it may not be the most efficient use of time, but that data is there. You just need to make that decision on whether that's something that's worth it for your organization. Another option you have is data archiving. data archiving migrates your full EHR data set into a separate web-based platform, but moving it to a, what we would call a secondary hosted or stored environment where your data will be present. So it's migrating the full data set of your data. It can also be able to be used, so one data archiving system can be used to migrate multiple source systems into a single solution. So if you're in an acquisition mode and you acquired 5 to 6 different groups, data archiving may be an option because you can put multiple systems into that one solution. You also have the ability to report on the legacy data, albeit separately, in the archiving environment. It can typically be a cost-effective solution. Instead of the capital cost, you have a higher operating cost because it's something that you need to manage and maintain and pay for support for the long term. And it can provide full retention requirements with audit history and selecting the length of data that you're wanting to migrate over to meet those retention requirements. Again, the cons, there's lack of actionable data. The provider won't be able to go in and access and the meds, allergies, and problems that were from the source EHR, they'd have to enter them again into the target system to be able to track those. And as I mentioned earlier, it becomes an operating expense for the organization. So based on your preference for how you manage your costs, you may be wanting to get rid of an operating expense, and this may not be an option for you. So the last option for data migration is what I call the hybrid approach, which offers a best-of-breed approach to your clinical data migration. It allows you to combine the options that provide the best chance of meeting your data migration goals. So for example, a hybrid data migration, you may select to do a discrete data conversion for the last 2 years of your problems, meds, allergies, notes, and vitals. But then choose to do a chart summary or data archival for the last 10 years for your ambulatory patients and last 20 years for your minor ambulatory patients. So you can see with this option, you're able to select your best of breed to meet your goals. It allows you for data flexibility, and it gives you roles and responsibilities of data, meaning that the discrete data's role and responsibility is the last 2 years of clinical data entered into your source EHR that's been migrated. You can say that, and then the archiving will take care of your retention so that you can then shut off your source EHR. You can also have a reduced licensing agreement as an option for your retention requirements and maintaining that. It gives you the options to make decisions based on what your organization wants to do and the costs associated with that. So the cons of this approach are typically there's multiple projects that you'll have to manage, and it could lead to data confusion. And what I mean by data confusion is where a provider wants to know where their lab results are. Well, was that converted discretely? Is that in the chart summary, or was that entered in an archival solution? You can see where that can come from if you can play that out in your mind across your organization. So understanding the data, communicating that is key to a conversion. So with that, we're heading to question number 3.
Thank you, Taylor. So for this poll, we're just kind of interested in what some of the concerns that you have while you're planning your data migration. So we've seen people that have had a condensed timeline, so fear of being able to get it done on time, the cost, and some people just have fear of not really knowing what the process is going to be like. So we're just kind of interested in your top fears. Looks like so far we've got cost, timeline, and then cluttering the existing EMR, which is another one that we've definitely seen where, doing bulk loads of data has, gets added to the existing EMR. It makes it kind of difficult sometimes for providers to be able to sort through all of the data. So it looks like those are sort of the major ones right now. I'll leave this open for about 30 more seconds and pass it back to you, Taylor.
All right, thank you, Galen. So in closing, I put together a list of ways to ensure a successful data migration. So the first one is plan ahead and involve stakeholders as decision makers up front. When you look at migrating your clinical data and you understand your timeline, make sure you can plan ahead, identify the stakeholders in your organization that need to be part of this conversation. Have them included early on to make decisions on the data that you wish to convert, understand the source, the target system that you're migrating to and their options. Bring in a conversion vendor with experience to help you help you make decisions on if a stakeholder wants to convert data. Is that possible, or is that something that needs to be removed from the tables of consideration? Number two is set a data migration goal. This revolves around setting goals or a charter based on what you wish to accomplish with this clinical data conversion. And it goes to more of aligning along a hybrid approach or documenting how you want your data to be migrated. What are the goals? What do you want your documents? How far back? What's the patient population that needs to be converted? What are the labs that would be converted and not be converted? Do you want to not convert certain data elements, and what fields are integral to your organization? Also setting some goal timelines. You want to have your discrete conversion typically done prior to go live of your EHR, so that your clinical staff can have that data at their hand, and the physician can have that data when you go live on your target EHR. The third being create and stick with a testing plan. When we do clinical data migrations, we have a testing plan and process that we stick with, and each vendor may have a recommended process that you would want to consider and adhere to. Testing plans can encapsulate multiple rounds of testing, can include the different document types, can include testings of the mappings, but make sure that you create one and that you stick to it so that you're comfortable with the data that's being converted has been validated, and you won't have any issues of bad data migration into your target EHR. The fourth is communicate across the organization. So there's different ways to communicate, and there's different reasons to communicate. Do you need to communicate with your providers and clinical staff? Who needs to understand what's going on? And then how is your data being converted? Is there potential of having the scenario where another practice is being migrated to your EHR as the primary EHR, and all of a sudden physicians and staff see data that they never entered being entered into the EHR? Was that communicated to the organization that data was coming across, and they should be looking for it and not be surprised at data that they didn't put in this patient's chart? And then if I work with an experienced conversion team, whether that's a resource that you have in your organization or a resource such as a conversion vendor, make sure that you have that as part of the planning process and then have them involved up front to help you and guide you through the clinical data migration. And that concludes the webcast for clinical data migration. We'll see if we have any questions that were entered by the attendees, and I'll do my best to answer them. Okay, here's a question that Alan sent me. Is there a way to convert only certain data elements, but not everything, to keep it as clean as possible? Yeah, and I think this question is referring to the breakdown of the clinical data that we discussed. So when you're looking at doing a clinical data migration, and your focus is on meds, problems, and allergies, you have the option of a multiple of ways to convert even within the meds. You can convert and look at converting active meds or inactive meds, and you may only want to convert active problems and not convert problem histories. And the same thing with allergies. And there's lots of nuances in the data that you're familiar with that you may want to include or exclude. You may not want to include allergy reactions. Most people do, but there are options where you can certainly handpick the data elements that you want to convert and which methods and options you want to convert them. Another question comes in along the timing of a discrete data conversion and how long a discrete data conversion could potentially take. Again, it depends on the size of your data set and how long you want to convert the data. Typically, a time frame of planning and converting your clinical data could be anywhere from 6 to 18 months, depending on the system that you're going to and the validation and testing plans that you want to put in place to ensure that your data gets migrated and mapped properly to go into your target EHR. Certain vendors have certain stipulations and mandate that you have a variety of testing that occurs before they would allow you to insert that data into production. It also may vary based on the type of conversion that you're doing. Are you going into a new EHR where that data being populated is going to be net new for the entirety of the organization? Are you going into someone else's EHR where you have to really review the duplication that can occur and minimize the chances of duplication and or overriding data that was entered by someone in your target EHR that you're migrating to? So it doesn't appear that we have any more questions, so I'd like to thank you for joining us today, participating in this webcast. Hope that it was helpful to you. And for additional assistance, please contact us through our website, galenhealthcare.com. Thanks for joining.